minute early because some of the speakers do have consecutive speaking obligations. And it's a pleasure to welcome you to this morning session on renal dysfunction. My name is Achim Jörs. I'm joining you from Cologne, Germany, and I'm chairing this together with Dmitro Gachinov, also from Germany, from Berlin. And we look forward to a distinguished faculty, and we'll start off with Professor Rinaldo Bellomo from Melbourne, who will make the case for measuring creatinine more frequently.
Thank you very much. If I can have the first slide, please. So first I'm going to talk to you about biomarkers in kidney disease and why they've become very popular. And then I will discuss what the biomarkers have in terms of merits and what they have in terms of deficiency. And then I will make an argument as to why just measuring creatinine more frequently may be a good idea. So I'm sure you're all aware that there's been a lot of interest in biomarkers in acute kidney injury and recommendations by organizations like Acute Dialysis Quality Initiative. The concept is that there are substances that can be identified in blood or urine that allow us to identify that a patient is particularly susceptible or at risk of acute kidney injury. They can appear more rapidly, more quickly in the urine or in the blood, and allows us to predict which patients are going to develop acute kidney injury. And a lot of this comes from proteomics. We now all know that in the urine of patients that are sick and potentially at risk of acute kidney injury, there's literally an ocean of peptides coming down into the urine, and they are usually small peptides. There's a list there which is not exhaustive. There's been a recent paper naming about 300 peptides that come down into the urine when you're sick. And it presumably reflects two things. One, the glomerulus is particularly leaky, and the second one, that the tubules cannot reabsorb these peptides when they're coming in such large amounts. And then there's been a proposal that when we classify acute kidney injury and we use creatinine and urinary output, we're missing out on an important signal, which is what the peptides and the biomarkers are telling us. And we should include biomarkers in the classification of acute kidney injury. And again, this is a controversial area and an evolving area. What are the major kind of peptides or biomarkers that have been studied in acute kidney injury? Well, the first one historically that dominated was NGAL, neutrophil gelatinase associated lipocalin, with work really beginning in the 90s, and there's quite clear evidence that if your NGAL is elevated, in addition to your creatinine and urinary output abnormalities, you are a person who's at greater risk of adverse outcomes, including mortality and renal replacement therapy and the composite of that. So they are, and certainly NGAL is a marker of being at higher risk. However, there are problems with NGAL. They are related, first of all, to the epitopes that are being used by the different manufacturers. So one particular NGAL assay is not necessarily the same as another NGAL assay, so it makes it really tricky to know what the accuracy of your product is in relation to another product. The other thing is that we don't really know exactly what it is that we're measuring. And the reason is that if we're looking at the measurements in the urine, and you look at what the urine is made of in terms of NGAL, you realize that there are three different kinds of NGALs. There's a monomeric NGAL, it's a chunk of NGAL in the urine. There is a dimeric NGAL, so there's NGAL attached to another NGAL. And there is a heterodimeric NGAL, it's NGAL attached to a different protein. And so when you start doing different ELISAs and you're using proteomics and Western blotting, you find that there is a mixture of all of these that is incredibly variable in different patients. And when you look at the predictive ability of different types of NGAL according to the assays that you use to measure it, and the kind of NGAL that you're measuring, whether it's a monomeric or a dimeric or a heterodimeric, where you're measuring the NGAL in plasma, you get very different signals about the performance of this particular biomarker. And it may be that the plasma NGAL, which is most certainly or most likely a reflection of neutrophil activity and inflammation, is the one that's associated with a greater performance in predicting acute kidney injury. It doesn't necessarily reflect that the kidney is sick or not well and about to develop AKI. It just reflects the patient are sick, and they generate neutrophil-related NGAL in the plasma. More recently, you'll be aware, there's been work in a large study called Sapphire that has identified two new biomarker, tissue inhibitor metalloproteinase 2 and insulin-like growth factor binding protein 7, which together have been marketed under the name of NephroCheck, which are cell arrest biomarkers that appear to be particularly strongly predictive of acute kidney injury and appear to perform better than other markers that are found in the urine. And they've been marketed and FDA approved as biomarkers of acute kidney injury from the Sapphire study. However, the performance of these biomarkers in the Sapphire has not been reproduced in other studies. This is data from the finicky study looking at chitinase-like protein, and you can see the performance of that versus NephroCheck. And you can see the performance of a NephroCheck in this study from Finland is way away from the performance of NephroCheck in the study of the Sapphire group. So that makes you worry that this is a reflection of particular group selection, it's a reflection of particular styles of management, and it is not universally reproducible and universally applicable. The guys at the Karolinska have also looked at this issue, and they've looked at the performance of the NephroCheck in their population. And again, it's actually been disappointing in that kind of environment. And you can see that the area under receiver characteristic curve for the prediction of AKI within 12 hours to 48 hours, within 12 hours and 24 hours is really poor in this cohort from the Karolinska Institute. Again, either suggesting that if you go in Scandinavia, NephroCheck doesn't work, or the NephroCheck is not robust to different populations and does not represent a reliable signal of risk. We've decided that if it doesn't work in Scandinavia, maybe it's going to work in Australia. So we've done a study looking at patients that fulfill the criteria for the Sapphire study in Melbourne. And this is a population of about 100 patients, of which about half develop acute kidney injury, so it's a very high-risk population. And one of the key findings was that the patients that develop a positive NephroCheck were significantly more likely to be oliguric. And so there is a clear association between a NephroCheck that's positive and oliguria. The two of them go together. And it's possible that NephroCheck signal becomes concentrated in the urine in patients with a low urinary output. And it makes it difficult to separate the NephroCheck signal itself from the signal of the urinary output, which, of course, if it is low, defines a greater risk of developing acute kidney injury. And when you look at the performance of the NephroCheck in predicting acute kidney injury stage 2 and 3 or a major adverse kidney event, it is okay in terms of negative predictive value, but does not have a good positive predictive value. And when you look at the area under receiver and operating characteristic curve, it's very disappointing, and it is similar in predictive ability to the findings of the finicky study in Finland, suggesting that whether you're really high on top or you're really low at the bottom, somehow things don't work as much as they work in the middle, which of course raises the issue that you've got a test that is dependent on the population where it's being analyzed, and therefore it is not universally robust to patient characteristics. So this is one of my mottos when I do research with my fellows, and it says, everything is bullshit until proven otherwise, including the things that we believe in. So let's question things. And one of the questions that came up to us is, of course, there is all this mythology around creatinine, that it's a really bad predictor of subsequent creatinine elevations. But most centers measure creatinine once a day. So there is this incredible hiatus of 24 hours where no one is actually monitoring creatinine. And then we make judgments about the performance of creatinine as a biomarker by not measuring it for 24 hours. That doesn't seem fair. And so we decided that we could measure creatinine more frequently, and we've installed in our blood gas machine a creatinine module. The creatinine module is based on the enzyme creatinine oxidase. And the first thing we wanted to do is validate it compared to the general laboratory measurements of creatinine. And you can see there that there is a pretty reasonably tight sort of limit of agreement between the arterial blood gas machine creatinine oxidase-based point-of-care measurement of creatinine and the measurement of the central laboratory, which of course opens up to the measurement of creatinine every time you do a blood gas, which in the ICU that I work in means every 4 to 6 hours. So then that, and you can see the nice correlation between the two. Then that opens the door to looking at whether you can get information from small shifts in serum creatinine over a short period of time between one blood gas measurement and another blood gas measurement, which is about 4 to 6 hours. So we look back at a population at risk, and we exclude a number of patients for a variety of reasons. The measurements were not available and so on and so forth. And we looked at a population of almost 400 patients. And the kind of episodes that we were looking at where there were small creatinine increases are, really small shifts. You can see on average, about 7 micromoles per liter. And if you look at the changes over creatinine over time per hour, it's very small, 2.3 micromoles per liter per hour. And that's a kind of population. And we're looking at all of these characteristics of this population. And you can see there that small changes in serum creatinine over a very short period of time are strongly associated with subsequent central laboratory measured, independently assessed changes in serum creatinine over 24 hours that we use to define acute kidney injury, with all the imperfections that, of course, go with such measurements. So it turns out that if you're measuring creatinine frequently over a short period of time, you see it shift. That is not a meaningless kind of noise, but it's actually a signal that you are a patient that's at higher risk tomorrow morning of having a significant increase in central laboratory serum creatinine. And you can see that the value of this kind of predictive signal of changes in serum creatinine is really not bad. And if you compare that to the NephroCheck data, in terms of sensitivity and specificity, it is just as good or just as bad as NephroCheck. But the difference, of course, is that a serum creatinine with the blood gas machine costs 47 cents. And then we decided that given that information, we wanted to do a prospective observational study to actually look at this in greater detail. And we've recently published that in the Journal of Critical Care. Again, we're looking at this population, which is about 380 patients. And what we realized is that these changes in serum creatinine actually are also particularly valuable if you place them in a clinical context where the patient already has significant risk factors for developing acute kidney injury. And particularly in our population, in my ICU, cardiac surgery, vasopressor utilization, and dramatically the presence of chronic liver disease in the ICU, together with a change in serum creatinine, all define a group of patients that are at very high risk of developing AKI, and then you can create a model where you allocate points to each particular variable. And we did that in terms of giving weight to each factor that would predict that you will develop acute kidney injury tomorrow. And so if you're on vasopressors, you get 3 points. If you've got chronic liver disease, you get 1 point. If there is a creatinine change of more than 1 micromoles per hour, per liter, over a period of 4 to 6 hours with the arterial blood gas measurements, you get 1 point, and then you can create a score. And you can see the score defining your risk of developing AKI. It's a little bit like the pulmonary embolism risk scores. And then you can construct a receiving operating characteristic curve, and you can see the models that are based on the combination of clinical and serum creatinine changes. Once you've got the score that combines those two signals, you've got an AUC which is almost 0.9, and no one's ever seen anything like this. And so it turns out that actually being able to monitor creatinine frequently and combining that with characteristics of patients allows you to develop a risk score which has got a really high performance in predicting that tomorrow morning you're going to have acute kidney injury defined by the KDIGO criteria. And the beauty of this is to give you an example of what it would look like. You're looking at serum creatinine. It's moved over about 8 hours with 2 arterial, actually there have been 4 arterial blood gases there. You can see the line moving up. You go from 70 to 78, 76. That doesn't look like much. Who cares about that? But it's happened. Something is moving, and then you can look at that in the context of the patient's condition, and you will be able to decide whether there is a very high risk and what the predictive performance is, and you can see that very nicely in the model. And then there will be the development of AKI. And this will happen several hours later. And so you've actually got time to intervene if you had a therapy for AKI, which, by the way, we don't have. But one day, maybe, we might have. But right now, we actually know it's on a... So this is like predicting the weather, all right? So this is a better way of predicting the weather. It turns out that if you go outside and you get a few drops on your head, then you know that it's likely that it's going to rain tomorrow. So let me conclude by saying that the concept of biomarkers are well established. There are multiple biomarkers. The clinical context has not been fully controlled, and different populations have performed differently. Creatinine is very easy to measure. It's very cheap to measure. And it turns out that creatinine is a really good predictor of creatinine. Who knew? Happy to take questions.
Thank you very much for this enlightening presentation. As Professor Bellomo has to move to the next talk in another hall, we'll take a few questions from the floor, if you would like to start. If not, I'd like to start.
Sure.
And what do you think is the current place of the other biomarkers in clinical routine? Do we use them? Do you use them? Should we do it, or should we just stick to it?
I've lost faith. I've lost faith. I was a believer, and now, like everyone that was a believer and doesn't believe anymore, I've become cynical and apostatic. Sorry. Just being honest.
Yeah, well, that's what we wanted to hear, yeah. Marlies.
Rinaldo, thank you. Can I just challenge you briefly? I think you were, I assume, I don't know, but I assume you were referring to novel biomarkers. But we do have traditional markers of kidney function, so urinary protein in general, some imaging. Do you also believe they are useless?
They believe I believe they identify patients at higher risk, but in terms of the performers as predictors of the development KD or criteria at a particular time, 12 hours or 24 hours, at the moment, no one's been able to actually, even the stuff that I've just shown you needs to be validated in another ICU, in another place. No one's actually been able to show a robust, predictive biomarker that performs consistently, robustly, like, for example, BNP in congestive heart failure across multiple populations, including proteins in the urine, microscopy of the urine. They just don't perform well, and they haven't been tested in large enough populations. Maybe they do, but, as I said, I've become cynical about all of this, yeah.
So some of the examples you showed where the serial creatinine measurement performs well was like cardiosurgery, liver patients.
Yeah.
But what about sepsis, where you have large volumes of fluid resuscitation?
Absolutely.
So does the creatinine go
So
down?
the answer is I don't know. The answer is I don't know. We're doing more work in my unit because now we've got this absolute ocean of blood gas-related creatinine. We're talking about thousands and thousands of measurements, and we're going to try and understand in different subpopulations what it can or cannot do. I don't know, so I don't have the answer. But I kind of, as I said, it's kind of a tautology, isn't it? Like creatinine predicts creatinine. I mean, like, yeah, of course it does. And I think historically, you must admit that it's crazy to make statements about creatinine when you actually measure it every 24 hours. It's like, really?
Yeah.
Right? It's like measuring the blood pressure once a day and making a decision as to whether somebody's at a risk of developing shock. It doesn't make sense, does it, really? Yeah.
Okay. Well, thank you very much.
Thank you very much, yeah.
From one star of intensive care medicine to another, my pleasure to represent to you Dr. Can Ince with kidney. He would like to talk about the kidney responses to the novel therapeutical strategies.
Definitely not a star, just a physiologist. So it's a great honor to be here, and my favorite organ, the kidney, the most important one, which is why we have two, So I hope to give you some new ideas coming from basic science, applied science. I'm from Rotterdam, and we had a department of translational intensive care there. at the Department of... I have some declared interests. I have a company that makes microcircuitry devices exhibiting here at this conference, but I will not be talking about that. And I have received grants from La Jolla Pharmaceuticals relating to angiotensin II. Most importantly, I'm a physiologist. I'm not a clinician. So my point is really to maybe shake the cage a little bit and make you think about some of the things that you're doing daily in a different perspective. So if we look, before we consider therapies, we first have to have an appreciation of what it is that we're trying to target in kidney. And it is very clear over the last years, and a lot of excellent work being done by the Australian groups with Professor Bellomo and Roger Evans and Clive May and others, showing that it's the renal microcirculation and the oxygenation of the kidney which is the real problem in tackling therapies. So if you look at all of these issues which cause kidney injury, they all ultimately affect the renal microcirculation and cause an abnormal oxygen transport. So this has led us to this model basically as a model to move forwards and to try and understand how to deal with the acute kidney injury. And the important thing about this conceptual model is that there is no magic bullet, and you know that better than anybody. So the idea of giving one drug and expecting a whole palette of pathophysiological effects to be solved is never probably going to happen, which is probably why steroids work so well, because they do attack a lot of the issues. So it really starts with a leukocyte endothelial inflammatory response, which causes a dysregulation of the homeostasis between oxygen, nitric oxide, and reactive oxygen species, which under normal physiology are very well balanced, and this causes damage to the microcirculation, resulting in acute kidney injury and dysfunction of the thing. So if we take this into account and we first deal with the oxygenation, this is an interesting study, again, done by the Australian groups, looking at a hypoxia stain. And one of the most important phenotypes of hypoxia in the kidney is that it's very heterogeneous. In all of the images, etc., that you do, if you do not look at the heterogeneity of the hypoxic response, you miss the pathological hit. Why is that important? Because if you've got little areas of hypoxia next to little areas of normoxia, that is a classic reperfusion injury model. So this heterogeneity of hypoxic state is really fueling the reperfusion injury in the kidney. And we have done quantitative oxygen measurements looking at the distribution of the oxygen pressures on the kidney cortex. And you see in these histograms very clearly a hypoxic element in each time that you look at the diseased kidney. Just to take you back here again, so if you give endotoxin to an animal, you get an immediately decrease in urinary output and a mean arterial pressure. So the obvious way to do this is what happens when you give fluid resuscitation. Well, when you give fluid resuscitation, you're very well able to improve the macroscopic parameters, but at the tissue and the microcirculation, it gets worse. So fluids are really a bad thing for the kidney. Again, I'm speaking as a physiologist. Here you see a very classic example. The mean arterial pressure is very nice. Here the endotoxin results in a decrease in renal blood flow. Immediately when you give fluids, things go up. The mean arterial pressure sort of tries to get better. But if you look here at the microcirculatory PO2, you see that fluid resuscitation, which decreases the oxygen carrying capacity of blood, dilutes the blood, results in hypoxia in the cortex, and you see also a damage in the tubular cells with an increased oxygen consumption per sodium reabsorbed, which is the golden standard for renal function. I will move on. Anything that you do with fluids causes a lessening of the oxygen availability in the kidney cortex, seen here by Mathieu Legrand, who was in our lab for many years. Fluid resuscitation, even though it does correct some of the inflammatory markers, causes regional hypoxia. So what about the clinics? We looked at all of our patients over many years. This was about 5,500 patients. And we asked a very simple question. If we just look at anemia, according to the World Health Organization definition of anemia, which is 7.4 millimolars. We found that it was the most sensitive, specific predictor of acute kidney injury in our intensive care unit across the board. Anemia is really a bad thing. And it is ironical how little we talk about the importance of oxygen transport and red blood cells. So the only effective way of increasing oxygen availability in the tissues that you have in your unit is blood. There's nothing else. Fluids are bad. It's a lot of salt and water, has got an oxygen carrying capacity of less than 2%, and just is cosmetic anesthesiology, in my opinion. And if you look a bit more critically at the blood transfusion literature, you do see that giving blood, modern blood, not the old blood of the Herbert studies with leukocytes and all sorts of other stuff in it, but modern blood that we have here in Europe, leukodepleted, well stored, also not older than 30 days. In the US, it's 45 days. Then you see that if you start to hemodilute patients below 25%, that then you start to get more incidence of acute kidney injury. And indeed, if you look at some of the more modern transfusion trials, you see that having a good hemoglobin level, especially for the elderly patients, is really important. This was an old study done, very relevant still today, especially for the patients above 65. Having a high hemoglobin, a good hemoglobin, is really important, especially for your cognitive function. So another experiment here done by Mathieu sees it again. If you now give a hemorrhagic shock and you give saline, you're very able to improve the mean arterial pressure back to baseline. No effect on oxygen at all, only blood does it. And similarly, in an endotoxin model, you see that if you give blood, this is Lara Zafrani, who did these experiments in our lab, in endotoxic shock, you see that if you give crystalloids, it goes up momentarily and just disappears into the tissues. There is nothing good about crystalloids in terms of oxygen transport at all. It doesn't stay in the intravascular space, it disappears into the interstitial space, and it hemodilutes the oxygen carrying capacity of blood. So what about inflammation? Well, inflammation is a really important target, actually. And there's a lot of stuff. So let's start with some anti-inflammatory approaches. So we looked at some novel. This is myophenolic acid, MMF, used a lot in transplantation. It's a strong anti-inflammatory and is being looked at. The advantage of this is that you can take it orally. And we saw a great down regulation of INOS, IL-6, improvement in the NGAL, etc. And even the lactate, as you can see here, improved when you gave MMF. N-acetylcysteine, also an old drug, is very effective. Now, all of these drugs should really be given prophylactically. And that's another elephant in the room, is that people wait until all things are going wrong and then start to get drugs out of the cupboard. It's much better to have them before the actual injury occurs than following the actual injury, because repairing injury is a completely different physiology than preventing injury. So what about the microcirculation itself? Well, prostacyclin and iloprost have always been a very interesting compound. And these are, of course, phospholipid products targeting the arachidonic acid pathway. And they have basically anti-inflammatory drug effects. And because of their effect on the potassium hemostasis, they also result in reduction in intracellular calcium, causing vasodilation. And you can really see quite at the bedside some impressive effects of the use of iloprost, which is an analog in patients in septic shock, this study done by Mathieu Legrand. We did basic science studies also, and here too we saw that we were able to improve the hypoxic areas in the kidneys very effectively by giving iloprost, and also improving the sodium, the oxygen consumption sodium reabsorption ratio in the tubular cells. And now there's a trial being conducted by a number of colleagues called the iMicro trial, looking at the effect of elomodin, which is a prostacyclin analog, which might be very interesting. So what about angiotensin II? Angiotensin II has been around for a very long time, and a lot of studies have shown that it's a very, very effective vasopressor. And it really it affects the afferent arterioles very specifically, in contrast to norepinephrine, which is also on the afferent. And this is hemodynamically speaking, a very, very different effect. And as you are aware, maybe the Giapreza synthetic angiotensin II, which has come into the market, also recently been approved in the European Medical Agency as a treatment for catecholamine-resistant hypotension, has been shown to be very effective in doing that. And some studies have been done already looking at renal replacement therapy treated patients and the improvement in survival when using this angiotensin II as an effect. So this was Ming Shuola, which many of you will know, and when he was at La Jolla, we initiated an animal study, and we found some interesting aspects of angiotensin II treatment. Not only was it very capable of improving the blood pressure, what was interesting about the angiotensin II was that it also does it very slowly, as opposed to norepinephrine, which was much more immediate, and we also saw an improvement in the urine output. But what was most interesting about the results that we found was that it also had a strong anti-inflammatory effect. So this was something new. It surprised us, and we actually also looked at the histology and found much less tubular injury following angiotensin II. So this is probably an interesting alternative to the use of norepinephrine in treating hypertension. The last drug I want to think, and then I'm finished, Chairman, I'd like to thank you very much for your patience, is pentoxifillin. It's also one of those drugs from the old times. But you know, old drugs really do work. The only reason we don't have them anymore is because the patent ran out. But the pentoxifillin actually is a very, very interesting, cheap drug. And it's the neonatologists who are very, very interested in pentoxifillin, and they reached out to us and asked us to do some more research into it. So if you look at the Cochrane analysis of pentoxifillin, they are very impressive that there is really a decreased all-cause mortality in the treatment of sepsis. So if we look at pentoxifillin, what actually pentoxifillin does, it's very similar to what iloprost and prostacyclin does, in that it causes a reduction in the anti-inflammatory, in the inflammatory mediators, and has got all sorts of other effects related to improved hemorrheology in the microcirculation. And here are some studies. The first thing that's very clear is that you can see, and you can see this in patients too, using our microcirculation devices, that there is a reduction in the leukocytes that stick to the endothelial cells. And as you saw in our first image, that's one of the first steps really in the inflammatory insult to the kidney. And if you look underneath the microscope at the capillaries, you see a vasodilation. And what vasodilation does at the microcirculation, it improves oxygen extraction. And that's the benefit that a drug like pentoxifillin and vasodilators in general have, is they increase the diffusion, or they decrease the diffusion distance by recruiting the microcirculation, and that translates itself to improved oxygen extraction by the tissues. Also very important for COVID, by the way, but that's another story. So oxygen extraction was very important. And then you see also that that's a benefit for the renal function in these early studies being done, showing improved glomerular filtration rates. And this is, of course, a classic study, a very old study by David Bihari now in Australia, showing oxygen extraction. This was in the time we were talking about VO2, DO2 issues, and it was the only study that really showed, dopexamine really never showed that, but that showed an improvement in oxygen extraction, which is a prime oxygen deficit in sepsis, really. So, and we did studies also on pentoxifillin, and we're able to show that it has got a very beneficial effect on hyaluronic acid, which is glycocalyx, and endothelial. So all in all, it is, you see that these drugs which are effective target multiple pathways, and that silver bullets are really a bad approach if you want to start to even think about something like acute kidney injury. Well, this is a very good friend of mine, Professor Sun from Taiwan, who says the true source of qi is the kidney, which I really think is beautiful, and this is beautiful calligraphy that says that. Thank you very much for your attention.
Thank you very much for this enlightening presentation. Any questions? Please.
I understood you seem to make a point that elevating the hemoglobin by doing transfusion could be better in some patient groups. What I'm wondering is, if you do that, so we will increase the dynamic viscosity of the blood. So what happens to the microcirculation then? So if you go above a certain threshold, or is there a threshold?
Yes, so that's a great question. The idea that viscosity is bad stems from, I don't really know. Viscosity is the most important parameter which is responsible for autoregulation and for regulating vasotone, because it's the viscosity which interacts with the endothelial cells and allows vasodilation and contraction to occur. So as soon as you start to alter the viscosity by anemia or by giving fluids, you take away the autoregulatory capacity, really, in the kidney and also in the brain. So actually, the blood is the perfect colloid. It's a viscous compound which allows you to recruit the microcirculation, which we see in COVID, by the way. In COVID, you see a change of the hematocrit from the systemic circulation to the microcirculation. Hematocrit goes down in the systemic circulation and increases in the microcirculation, which causes more viscosity, which recruits capillaries. So actually, I would, respectfully say it's the other way around. You are adding viscosity to the equation, which is good for the hemorrheology and for the oxygen extraction capacity of the tissues.
I have another one. Dr. Bellomo wasn't very optimistic about the markers which are allowing us to find the AKI.
Yes.
What about you? Do you have an optimism that we find out?
I do indeed. I do indeed. So I was saying to Marlies when we were sitting next to each other, I also am a great favor of creatinine. However, I start that lecture by explaining Shannon's and Nyquist's sampling law, which none of you have probably ever heard of. It's first-year electrical engineering standard thing, and it's the sampling theorem. And it basically says that if you have a black box, this comes from nuclear centers, from your phones, and everything to do with signal processing. If you have a black box that you want to control, say the kidney, and you're taking an output parameter, which is the most essential parameter, which controls that process, and giving it as a feedback to control the process, which is basically every servo system, it says that if that system is changing with a certain time constant, t, that you have to sample that at least 2 to 3 times more frequently than the time it changes. So if we take that into consideration, and we say, okay, creatinine, let's say, is the parameter which is important in understanding what's going on and how to control acute kidney injury. And we also say that acute kidney injury can develop in 2 to 4 hours, which is true. It means you should be sampling at least once an hour if you want to use creatinine as a way of avoiding a disaster. So I would go a step further than Professor Bellomo and say we need continuous creatinine. And that maybe would be a way to avoid acute kidney injury.
Thank you very much.
Thank you very much. Oh.
I'm a clinician. It seems that pentoxifylline can prevent AKI. So do you think that we should use as a prophylactic agent when we are concerned about AKI in a clinical setting?
Well, first of all, I'm not a clinician, and I feel very nervous about questions like this because if I was a patient, I would like, the moment I enter the ICU, to get 1 gram of vitamin C and 1 milligram per kilo dexamethasone. And I think this would probably save me with all the crazy stuff that you guys do to patients from that on. That is not a serious comment, by the way, but I believe in prophylactic medicine, and that's something that unfortunately we never hear anything about in intensive care medicine. Thank you very much.
Okay, I think that was a great final statement. Thank you very much. And we now move on to the next presentation, which is by Professor Marlies Ostermann from London. And she will discuss with us the role of different AKI subphenotypes. Marlies.
Thank you very much. Thank you, Mr. Chairman, and thank you to the organizers for inviting me. It's a great honor to talk to you about AKI subphenotypes. And I hope I can convince you that that's crucial to make progress in this field. As Professor Bellomo already said, we haven't got a therapy for acute kidney injury, but I believe that the identification of subphenotypes may help us. I have no conflict related to this talk. So acute kidney injury is a syndrome. There are thousands of different etiologies, and there are thousands of different clinical pictures of acute kidney injury. And ultimately, the phenotype, which we see at the bedside, and the trajectories and the prognosis depend on so many things, on the patient factors, the triggers of AKI, where you are, where the AKI is diagnosed, and so forth. It also depends on all the other things we do, so the type of fluids we give, the settings of the mechanical ventilation. So it's a very multifactorial, multidimensional syndrome. In patients in hospital, sepsis, post-cardiac surgery, and drugs are the most common causes of acute kidney injury. When you look at the underlying pathophysiology, then we've made real progress. We understand much better now what can potentially lead to acute kidney injury. So we now know that inflammatory processes play a role. We know that direct tubular toxicity plays a role in some forms of acute kidney injury. It's very clear that microvascular dysfunction is prevalent in a lot of forms of acute kidney injury. The mitochondria play a role, and mitochondrial dysfunction has been recognized as a very important pathophysiological player. So our understanding of acute kidney injury has really advanced. We also know that the trajectories are very different. So some patients recover kidney function very quickly, in others it takes longer, and some patients sadly never regain baseline kidney function. But when patients are at their peak of their creatinine, at the moment, we have very little tools to predict who will recover and who won't. And the tricky part is that we only use one biomarker. We use creatinine to diagnose acute kidney injury for any forms of acute kidney injury. And I believe this is one of the reasons why we've not made much progress in finding tools to treat or prevent acute kidney injury. Now, I've already said we've made advances in the pathophysiology understanding acute kidney injury better, and there have actually been real advances related to molecular nephrology. We now know that, from experimental studies, we know that different etiologies, different triggers can really elicit very divergent pictures within the kidneys at molecular, cellular, genomic, and functional level. And just as an example here, this is a figure, a scheme created based on experimental studies. And if you create and cause acute kidney injury in the animal lab, either by causing severe hypoxia or severe hypovolemia or tying of the renal arteries, then this triggers different metabolic pathways. And this is important, not only to understand acute kidney injury, but this is extremely important if we want to make progress in finding therapies, because you would want to find a therapy that potentially targets one of these crucial steps. And just to expand on this, again, two mouse models of acute kidney injury. One caused by acute hypovolemia, severe hypovolemia, and the other one caused by arterial ischemia, so tying off the renal artery for a while. The mice in these animal models had the same creatinine level, and to the investigators in the lab, they looked exactly the same. And although they looked the same, at molecular level and histologically, they were very different. So different pathways were activated, so pro and anti-inflammatory in some of them. And at histological level, there were changes seen in different parts of the kidney. Another model of sepsis-associated acute kidney injury, where rats were given LPS, or endotoxin. And again, when the rats were sacrificed, the LPS was seen in different parts of the nephron. So very specific histological molecular changes depending on the trigger. And worryingly, although all these animals had a similar creatinine level, there was less than 10% common gene activation. When they measured biomarkers, then there were differences. So different biomarkers, as they stem from different parts of the nephron, they differed. So they were able to differentiate between these forms of acute kidney injury. We now also know that sex, as a biological variable, plays an important role. And in the lab, female and male mice or rats behave very differently to these triggers. And it is possible and likely that this also is relevant for humans, and in particular probably for adolescents and AKI in adolescence and puberty. And again, that's a very exciting area which is being explored at the moment. And just to finish this, again, I want to show you these experiments here, where the investigators try to investigate the role of acute kidney injury in animals with impaired cardiac function. And they used 3 models of cardiac impairment. So in one, the coronary arteries were ligated, in the other one, cardiac arrest was induced, and then the mice were put on cardiopulmonary bypass. And again, the same creatinine level was achieved, but histologically, the kidneys looked differently, and they all had displayed a different biomarker profile. So the biomarkers were able to differentiate between these types. Now, I personally find this extremely exciting. I think this is really broadens our understanding of acute kidney injury. The problem, obviously, is how to translate this to the bedside, because at the bedside, AKI is often multifactorial. It's not just one trigger. It's the person with sepsis and some nephrotoxic drugs and hemodynamic instability. Furthermore, at the bedside, we often don't know the exact onset of the nephrotoxic insult. We have no idea when it really happened. So it's difficult, would be difficult to interpret biomarker profiles. And then lastly, these animal models also show that the initial trigger may be very specific in response to, and the response may be very specific in response to the trigger, but then it leads to secondary effects, often inflammatory effects. And then down the line, it may be difficult to differentiate between these different etiologies. So that's exciting, but also, again, still very challenging. But I do believe it is important, because if you just even focus on one type of acute kidney injury, where we think this is one particular type and we recognize it, say AKI in the context of sepsis, I'm afraid, I put it to you, patients are never the same. There's so many forms of sepsis-associated acute kidney injury. Just as an example, a study here where they looked at sepsis in the context of following a surgery. And again, some patients developed AKI, and some patients didn't develop AKI initially, but some developed AKI a little bit later, after 3 days. And when you looked at their prognosis, their initial trajectories, say at hospital discharge or later, even at 1 year, it was very variable. There was just no pattern. It was impossible to say why some patients made a really good recovery and others still had impaired kidney function at 1 year. I do think we need to look into this in more detail and see whether we can identify particular subphenotypes. And it is possible now with modern advanced statistical analysis and also with the help of biomarkers to identify specific subtypes. Just one example again, it's back to the Fenaki study, which Professor Bellomo already showed. This is a very impressive database with data of all ICUs in Finland. And they've been collecting data for more than 10 years. And in the beginning also collected samples for biomarker analysis. So they went back and identified all patients where the clinicians had labeled patients as having sepsis-associated acute kidney injury. So to the clinicians, this was AKI due to sepsis. And then they looked at all the patients who had a complete biomarker set and were able to identify 2 subphenotypes using very advanced latent analyses. And as you can see here, these patients who looked the same to clinicians at the bedside were actually very, very different. They differed in many aspects: the form, the type of sepsis, the initial trigger, pre-existing comorbidities, but also in their biomarker profile. And more importantly, they differed in their outcome. So subphenotype 2, doesn't matter, one of them was much more likely to progress and unlikely to recover kidney function and had a much higher mortality. Now, recently, international experts got together to explore the whole issue of sepsis-associated AKI a little bit more and see whether we could make a bit more sense of this and identify subgroups that would be relevant for the bedside. And the report of this meeting has just been published last month. And essentially, the current data tell us that sepsis-associated AKI is a very heterogeneous problem where many different pathways and pathophysiological processes contribute. But not everybody with sepsis-associated AKI has the same underlying pathophysiology. So in some patients, it's predominantly microvascular dysfunction. In others, it's a neurohormonal disorder. But this probably explains why we see so many different endotypes, and importantly, why we see so many different phenotypes at the bedside. It's confounded further by the fact that obviously we treat the patients at the bedside and we may give them nephrotoxic antibiotics for their sepsis, or we may give them a particular type of fluid as part of the sepsis treatment. And again, this contributes or may contribute to the development of sepsis. We may also do things which have nothing to do with sepsis, but actually are also nephrotoxic. We may put them on high pressure ventilation, or do things which ultimately contribute to this nephrotoxic insult. And all of this together, we believe at the moment, contributes to the development of so many different phenotypes of sepsis-associated AKI alone. Does it matter? We believe it does matter because different phenotypes probably respond differently to individual therapies. Only if we find these phenotypes and then test them properly will we be able to find therapies. And just as an example, I show you this analysis, which now stems from our ARDS experts. So a group based in California reanalyzed 2 existing databases with really mainly patients with pulmonary disease, ARDS, and some inflammation. And they identified all patients who had met the criteria for AKI. And then again performed very sophisticated latent analysis. And were again able, similar to the Fenaki study, able to identify different phenotypes. And they differed in many aspects, but they also differed in this biomarker profile, which were all endothelial-related biomarkers, not even kidney-specific, because this was not an AKI database, this was an inflammatory ARDS database. So they identified 2 different subphenotypes, and then they used this information and applied it to a different database. Before they did this, they showed that these 2 groups indeed were different in many aspects, but also different in outcome. So patients with so-called subphenotype 2 had a much higher risk of not recovering and dying within 28 days. When they applied it to the VAST database, a completely different database, but a VAST database, which was a database related to the VAST trial, comparing the role of vasopressin, looking at the role of vasopressin in patients with septic shock or noradrenaline. They found a difference. Now, the VAST study originally is a negative study. It didn't show a role for vasopressin. when they applied the biomarker profile or validated the biomarker profile in this database, they showed that patients with subphenotype 2 indeed also didn't respond to vasopressin, but patients with subphenotype 1 had a really good response to vasopressin. And so this essentially to me means that identifying different phenotypes in a category which is sepsis-associated AKI may help us finding those who will differentially respond well to a particular therapy and those who will not respond. And this study led to an editorial by eminent nephrologists, again urging us to look at identifying particular subphenotypes so that we can find those who may respond and those who may not respond and come to harm. I believe we have to do this in conjunction with the other organs so that we can find targeted therapies and move away from what we currently do, where everybody with AKI gets treated and managed according to some sort of recommendation or bundle. But if we find those if we find these subphenotypes, then we can treat them and treat those who respond well and avoid treatment in those who are likely to come from harm. Plus, we will be able to find treatments. And with that, I want to finish. Thank you for your attention.
Thank you, Marlies. Questions from the floor? There's one.
I wanted to ask specific biomarkers for specific phenotypes.
Oh, there. Okay. Yeah.
So I was wondering the specific biomarkers for the two different phenotypes that you show. Mm-hmm. Can you tell us more about this?
Yeah. So these are endothelial biomarkers, angiotensin, angiopoietin 1 and 2. There's an inflammatory biomarker, interleukin. These databases were never created to look at acute kidney injury, but I think to find these the kidneys don't act alone. They are surrounded by all the other organs. They receive the output. They receive some of the biomarkers from other organs. So to me, it doesn't matter that it's biomarkers from other organs. I think the whole biomarker area, for me, I think is exciting because it gives us much more information about potential pathophysiological process within the kidney, but also in the surroundings, and the kidneys react to this. So the ones which I showed were inflammatory biomarkers.
The concept of precision medicine is apparently very successful in certain areas, like in hemato-oncology.
Absolutely.
What I'm wondering is, given the limited set of interventions available to us nephrologists and intensivists for AKI, where do you see the distinction in the approach of treatment? Because we have the fluid resuscitation, avoidance of nephrotoxic drugs, and only so many tools available to us. So where do you see the different directions to move to?
A really good question. I think the chicken and egg question. Which one is first? I believe we have no therapies because we've tested therapies in everybody who had a raised creatinine, and we haven't tested the therapies in specific subphenotypes. So I think we have to identify them again, and then test the physiologically most logical therapy. So if we want to test, for instance, if we believe that microcirculatory dysfunction or arterial vasodilation plays a role in sepsis-associated AKI, then we may test a vasoconstrictor in those where we believe it is some glomerular hemodynamic problems. If we think it is predominantly a mitochondria problem, then, and that's being done, there are currently some drugs being tested which address the mitochondrial dysfunction. My concern is they will test, again, all comers, and this study is likely to be negative.
Yeah. So basically what you're saying is, if you put 1,000 patients with different etiologies in one study, for example, trying to identify the ideal point to start acute renal replacement therapy, then inevitably nothing will come out at the end.
Correct. Yeah. So, I mean, you could say, what's the point in doing subphenotypes when you haven't got anything to treat them with? I accept that. But I would say we do this and then start testing therapies again properly.
Okay.
Another question to the biomarkers. Thank you, by the way, for the presentation. The interesting topic is that we have a very heterogeneous population with the AKI, even in sepsis. And then we test one biomarker, and we would like to validate those biomarkers on another cohort of very heterogeneous cohort. No wonder that it's not going to work.
I fully agree. I fully agree. So, and all these biomarkers, they have a profile. So they go up after a particular trigger, and they are at their peak, some at 4 hours, some at 6, some at 12, some whatever. And they stem from different parts of the nephron. So first of all, if you want to validate them, if you want to test them, you have to test and measure them at the right time point when they have a peak. And it's so different for all of them. So it makes no sense to test all of them at the same time. And if you want to validate them, again, you have to measure them at the right time.
Thank you.
Okay.
Yeah. Thank you very much. Our next speaker is Professor Thierry Gustot, who would like to tell us about the renal dysfunction management in patients with cirrhosis. Thank you very much.
Thanks a lot. My talk is more clinical, and then I will address the frequent question of AKI in patients with cirrhosis inside the ICU. The current paradigm of the physiopathology of AKI in cirrhosis is based on the fact that portal hypertension creates a splanchnic arterial vasodilation and a reduction of the total volume circulating. And then this induced several activation of the neurohumoral system, renin, angiotensin-aldosterone systems, or vasopressin system that induced vasoconstriction in the kidney. And when you look to the patient with cirrhosis without AKI, and you measure the resistive index inside the kidney with ultrasound, you see that the patient with cirrhosis have an increase in vasoconstriction at baseline in the kidney. And when we look to the cortex, you see that this vasoconstriction is increased with the severity of the cirrhosis, as you see here, patient with treatable ascites and patient with refractory ascites, you have an increase in vasoconstriction, underlying the fact that these patients are susceptible with a trigger to develop AKI due to this fact. And as you see here in this cartoon, that some complication frequently seen in cirrhotics, bleeding or sepsis or hypovolemia, worsen this syndrome and this splanchnic arterial vasodilation and create the kidney injury and particularly hepatorenal syndrome. When we look to the frequency of acute kidney injury in cirrhosis, is very frequent, as you see. It's observed in 1/2 of the patient hospitalized, and nearly 60% of the patient admit to ICU. And when you look to the etiology of this AKI, it's very rare that it's post-renal, but the debate is between pre-renal and intrarenal AKI. Intrarenal is observed in 1/3 of the cases, and pre-renal AKI in 2/3 of the cases. The thing is that not very. It's an update definition, because in the liver field we don't use cardiac criteria in the past, but not we apply the classical criteria to define AKI in the cirrhotic population. And as you see here, there is a prognosis as a relationship between the prognosis and the stage of AKI in the cirrhotic population. And as you see, when you have AKI stage 2, you have a mortality rate intra-hospital, about 60% is very high. And also, the prognosis is dependent on the etiology of AKI in cirrhotics. You see the best prognosis is associated with intrarenal AKI, followed by hypovolemia, infection, and finally, the most severe form, hepatorenal syndrome. When you have a patient with a cirrhosis with an AKI, you must review nephrotoxin, stop some drugs that we use frequently in cirrhotics, diuretics, non-selective beta blocker, and then you must always try to find an infection because it's a frequent trigger of AKI in cirrhosis, and you must perform some analysis in the urine to try to differentiate intrarenal than pre-renal AKI. Just to speak a little bit about biomarkers, but it's not explored in the cirrhotic population. There is only small number of paper about that. As you see, NGAL is the most used one, and as you see, to differentiate functional AKI, pre-renal AKI, and acute tubular necrosis, for example, in this study, the sensitivity and the specificity of NGAL inside the urine is not so bad, but it must be confirmed in other independent studies. Then, if you have the characteristics of pre-renal AKI, and I will center my talk on this topic, you must give fluid. It's the recommendation from the Society of Liver Disease, and you must make a free treatment with intravenous albumin, with the dosage of 1 gram per kilo, with a maximum of 100 gram per day. And you have a response or not based on the decrease of creatinine. And as you see, the response is frequently observed. It's observed in 2/3 of the cases, but in 1/3 there is no response to this volume treatment. The thing is that in this situation we talk about hepatorenal syndrome, AKI, HRS AKI. When you look to the criteria to define hepatorenal syndrome in the past, it's defined by the presence of cirrhosis, of course, and frequently ascites. And as you see here in all definition, it's not so all, but the cutoff value of creatinine is 2.5 milligram per dl. For a cirrhotic, it's very high, with sarcopenia and so on. And then we changed this recently, and we based on the classical criteria of AKI. Then if you have an increase of 0.3 milligram per dl and you have no response to fluid therapy, then you have an HRS AKI. Then, as I said, there is no response to liquid administration. Absence of shock is important to note this. There is no nephrotoxic drug that can explain the AKI, and also when the characteristics measure in the urine, absence of proteinuria, absence of hematuria, and a normal ultrasound is associated with this definition. Then I will go to the treatment of AKI HRS. First of all, about vasopressin analog. Telepressin, it's used in our specialty for a long time ago in Europe, not in US. And here it's a randomized control trial that compared telepressin plus albumin versus albumin alone. And here you see the probability to HRS reversal, defined by a creatinine lower than 1.5 milligram per dl. And you see that when you treat the patient with telepressin, the probability to have a reversal at 2 weeks, it's about 30% compared to 16% in placebo group. But there is no survival benefit associated with telepressin. is not surprising due to the fact that patients have a severe cirrhosis associated when you don't treat this problem at all. But when you perform a meta-analysis of whole trials exploring the effect of telepressin, it seems to be the use of telepressin seems to be associated with a better resolution of hepatorenal syndrome, an improved renal function, and just at the limit, but a survival benefit associated with this. The FDA asked to perform in US a trial that tried to confirm the European study, and as you see here, is nearly the same. It's a study that compared telepressin to placebo, and as you see, the HRS reversal is around the same than the previous studies, 36% at 2 weeks compared to 16% for the placebo group. There's no survival benefit, but when you look into details about the characteristics of the study published in New England Journal of Medicine, they used the definition of hepatorenal syndrome, the old definition, then you must have a creatinine above 2.25 milligram per DL. It's very huge. And when you look to the mean baseline creatinine of the patient included in the study is 3.5, then I think it's too late. And we know that the baseline level of creatinine is a major predictor of response to telepressin. But the most interesting thing is that when you divide a patient treated by telepressin as a responder and non-responder, there is a survival benefit associated with this response. There is another strategy to give telepressin. Maybe you know that, but the previous study is about intravenous boluses, but they compare with a continuous administration of telepressin. I will not go into details about that, but the probability to have a response is nearly the same. There is no difference in terms of prognosis, but when you look into details about side effects, there is less ischemia, peripheral ischemia, angina pectoris associated with telepressin with the continuous administration compared to the boluses. What about adrenergic agonists? I will go directly in this because there is no good study to compare noradrenaline to telepressin in this situation, but there is 2 studies that demonstrate that the HRS reversal is nearly the same when you compare noradrenaline to telepressin. I will just a small word about midodrine due to the fact that it's used in US for a long time ago because they don't have access to telepressin in hepatorenal syndrome. And as you see, midodrine plus octreotide, clearly you see here the partial response to this treatment in gray and in white, the total response, complete response, and you see that this probability is very low when you use this combination compared to telepressin. Then it's not a solution. As you know, there is in the past hope in the MAS system to improve hepatorenal syndrome. You know that there is one study, small study, that demonstrates survival benefit associated with MAS use in this situation with a decrease in creatinine, decrease in bilirubin. But when you look at a more recent paper that tried to analyze the effect of MAS in a patient with hepatorenal syndrome, you see that the GFR are not modified between pre-MAS status to post-MAS status is remain the same. And then you have a decrease in creatinine, but when you start the procedure, the creatinine goes up. And as you know, maybe the larger study, randomized controlled trial in ACLF, in acute and chronic liver failure, does not demonstrate any survival benefit associated with this treatment. What about the tips? As you know, tips is a shunt that we put between hepatic vein and portal vein. The thing is, it's a solution in some patient. There is case series that demonstrate some efficacy, but there is no good data. But the problem is the applicability of tips in this so sick patient with poor liver function, and we know that it can worsen the liver function in some patient. And just to finish, I will talk about liver transplantation, because when you have a hepatorenal syndrome, it's associated with very, very poor prognosis, and then we must think about always liver transplantation, and not combine kidney liver transplantation, but liver transplantation alone, because when you look to the evolution of creatinine after liver transplantation in a patient with hepatorenal syndrome, the decrease of creatinine is very rapid. And also, when you compare the survival rate, is not different from a patient with hepatorenal syndrome pre-liver transplantation compared to patient without. Then it's a good indication of liver transplantation alone. It's not the case when you have acute tubular necrosis. The prognosis is very bad. Then, just to finish, I will know that HRS-AKI is frequent and severe. Vasoconstriction therapy improves survival in responder. Tips, it's an option in selected patients, and liver transplantation is the only option at long term. Thanks a lot.
Thank you very much for the wonderful presentation, and just in time. Is there any questions from audience? Yeah, please.
For how long would you recommend to attempt telepressin treatment in patients with AKI HRS?
No less than 10 days.
10
no
days.
less than 10 days, due to the fact that when you stop early, the recurrence is very high. Then you must continue the treatment for at least 10 days, between 10 days and 2 weeks. We have several patients with, because we treat these patients on telepressin on the ward, not in ICU. We have some patients with a dependency to telepressin. When you stop, okay, you increase the creatinine and so on. And then we address this question by giving extra point on the waiting list for telepressin-dependent HRS to give a priority for this patient, because there is very high. And then the problem is that, maybe you know that, but the patient with cirrhosis classified on the waiting list is based on MEL score. MEL score is based on 3 parameters: bilirubin, INR, and creatinine. And the most impactful criteria is creatinine.
Or
Okay.
dialysis. So if you put them on acute dialysis,
or dialysis.
could be even higher up.
Yeah, this is a problem. And also, this problem is that when you treat the patient, you decrease the place of the patient on the waiting list. Then it's always a problem. And we know that if you decrease creatinine before liver transplantation, your success after liver transplantation is better. Then you must treat. And then we try to address the discretion to prioritize this patient due to this dependency on telepressin.
Yeah. I do have more problems with the MELD allocation thing, because if I look at a patient who has a long-standing liver problem, liver cirrhosis, with malnutrition, muscle wasting,
Yep.
in that patient, a creatinine of 2 has a totally different significance as in an
course.
otherwise healthy patient with AKI for sepsis or something like that.
Of course, totally agree.
Is there any place for extracorporeal liver support, except of bridge to transplant?
For bridge to transplant, yes, but not for HRS. At this time, there is no place. In my practice, we perform inside a trial plasma exchange, like in acute liver failure. It's not nearly the same protocol because I don't use high volume plasma exchange, but a volume of 1.5. because it's improved a lot circulation, brain failure, but this thing needs to be confirmed in a trial. We are ongoing trial, and maybe in 1 or 2 years we will have the results about that. But the other device, I don't use this because we don't have objective data to demonstrate the benefit.
Thank you.
Okay, thank you very much.
Thank you.
I think we move on. And it's a pleasure to call on Professor van Haren, who will tell us everything there is to know about the optimal blood pressure for the kidneys.
My apologies, I'm allergic to Windows computers. There we are. Good morning, everyone. Maybe people standing in the back, just come to the front. There's some seats here. Just find a seat rather than just standing. As you can see, I'm a collector of professorial titles, so if anyone has a university that needs another professor, please just give me an email. I have no relevant disclosures for this presentation, and I'm going to talk about blood pressure targets, asking you a question first. Who targets in their ICU, who targets a mean arterial blood pressure of 65 for most patients? Yeah, that's probably pretty much everyone, and that's in keeping with what we found as well. So the question, of course, is there an ideal blood pressure for critically ill patients? But of course, it's also a nonsensical question. As we've heard from the previous speakers, we need to go to personalized and individualized medicine, and one size fits all may work very well for SOCs, but there's situations where it doesn't work so well, as you can see, and there's another example where it doesn't really fit. So ICU patients are all different, and even when we do these studies in critically ill patients, they're all different. There's not one type of critically ill patients. When you narrow it down to shock, I mean, shock is heterogeneous as well. There's problems with shock studies because what is the underlying type or cause of shock? What are the patients like? How old are they? We know that shock affects different vascular beds and different organs in a different way. And we also know, and we've already seen that from some of the previous speakers, that different vasopressors and different treatments that we use for shock have different effects on different organs. So, for example, many years ago we looked at vasopressin before the VAST study in catecholamine resistant or dependent shock, and we found that vasopressin in these patients worsens gastrointestinal perfusion. But when you look at a similar study in septic shock patients, methylene blue, we found that methylene blue improves gastrointestinal perfusion. This is just to illustrate that when you use a vasopressor, and we have I think a talk later on vasopressin for kidney injury, different vasopressors have different effects on different parts of the body. Fluid boluses, I'm not going to talk about this too much, it's a different talk on fluid, but just want to highlight that we know that when you give fluid bolus in ICU for a low blood pressure, and this is one of many, many studies, it's often not very effective in getting the blood pressure up. So in ICU, low blood pressure is often the reason to give fluid bolus in 76% of patients in this study, but it only worked in about 1 in 3 patients. And in the other 2/3, the blood pressure actually didn't go up. And we've highlighted this in this review paper a couple of years ago, that when you give a fluid bolus, the blood pressure response is usually quite small and doesn't last very long. This is all this is to point out that, when we talk about blood pressure targets, we also, and I'm not talking about that anymore today, we also need to think about what are we doing to achieve that blood pressure target. So we need a target, but also we need to agree on the best way to get to that target. Where does the 65 come from? The 65 mean arterial pressure really comes from this study in 2000. It's 23 years ago from Ledoux. Small physiological study where septic shock patients were receiving noradrenaline to a map of 65, then a washout period, a map of 75, a washout period, and a map of 85. The blood pressure went up with more noradrenaline, but when you look at some of the physiological responses to that blood pressure, there was no improvement in lactate, there was no increase in urine output, And if anything, these last three markers of microcirculation and gastrointestinal perfusion, there was sort of a trend of worsening when you push the blood pressure up with noradrenaline. And we know, that's a slide from another talk, so I'll skip that. So for many years, we don't really know what blood pressure to target, and Jim Russell made this very clear in his editorial. The map of 65 has been tested in many other studies against a higher blood pressure target. The problem with all these studies has been that the intervention was short, the output or the outcome measure was often not meaningful, not clinically relevant, and there were small sample sizes, and the results were conflicting. Is a higher blood pressure better? Is a lower blood pressure better? And I think one of the issues that we've highlighted many times at this conference already is that we have, heterogeneity in our patients, so it may be useful for some patients and it may be harmful for other patients in one study. A meta-analysis a couple of years ago, looking at studies that compared lower and higher blood pressure targets, showed that if you increase the blood pressure, your cardiac output goes up, your heart rate goes up, your lactate stays the same. But interestingly, in hypertensive patients, if you push up the blood pressure, you have a lower risk of renal replacement therapy. And of course, this was an important hypothesis for this landmark study a couple of years ago, where 80 to 85 blood pressure target in septic shock was compared to 65 to 70. So the primary hypothesis was that it would improve outcome, mortality, but the secondary hypothesis, which is to me much more plausible, that it would improve kidney outcomes in patients with hypertension. Now, why is this plausible? When you look at hypertension in the population, in Australia, the majority of people over 55 are hypertensive. And in ICU, the median age, certainly in our country, is sort of 65 to 70. So that means that a majority of patients that come to our ICU have a history of hypertension. A similar figure in the States, about 2/3 of patients people over 60 are hypertensive. But then these patients with hypertension, they may not be aware. About 80% is aware, but they may not be on treatment. Only 70% is on treatment. They may not be on effective treatment. Only about 50% of patients with hypertension actually have their blood pressure well controlled. Now, this is older data, but more recent data doesn't show much improvement in that. So what did that study show? A nice separation of blood pressure, targeting 85 versus 65. There was no difference in mortality as the primary outcome, but, as sort of expected, patients who had chronic hypertension had a lower risk of kidney injury and a lower need for renal replacement therapy. So the conclusion of that study was there's no need to bump up the blood pressure in all comers in intensive care, but in patients with chronic hypertension, maybe, and the numbers needed to treat is only 10 to prevent one AKI by bumping up the blood pressure. A recent meta-analysis from last month, basically with some newer studies put in as well, comes to the same conclusion. There's no difference in mortality when you bump up the blood pressure compared to 65, but it does say that we still need more studies looking at the best map for patients to prevent AKI. This is Dr. Penwa. He's from Newcastle in Australia, and he runs a research program. We're doing this together, but he's the main researcher. And his question really has been, when he started his PhD many years ago, what if we look at the patient's pre-morbid blood pressure, the patient's own blood pressure, rather than just having the same blood pressure for everyone? What if we take blood pressure measurements from before the patient came to hospital and use that to target the blood pressure in ICU? This is the blood pressure distribution in the Australian population, and you can see that the distribution is quite wide. And just pay a bit of attention to the different arrows. All these blood pressures are in normal, healthy people. So some people have a blood pressure of 90 over 50, and some people have a blood pressure of 130 over 86. So the top is systolic, the bottom is diastolic, and there's also the cutoff for the diagnosis of hypertension for both numbers. When you transplant that into intensive care, and you have these 4 different groups of blood pressures that are normal in a normal population, and you target 65 in all these patients, there will be a significant proportion of patients that have much lower blood pressures in ICU than they normally have at home. And we call that a blood pressure deficit. So we're creating a deficit, a lower blood pressure than what they normally would have. Now, does that matter, that deficit? Well, that's the thing that we're researching. So the first step that Rakshi did was he validated a protocol to get a basal blood pressure, because you can't do 24-hour blood pressure in these patients before they come to ICU, because they just rock up in your ICU. So you have to call the GP or look at hospital notes, previous blood pressures at the end of their previous admission. So there's a whole protocol for estimating a patient's pre-ICU their own blood pressure, and it works very well. And so we're basically looking at some ambulatory blood pressure readings in the last 3 years, and maybe a record of previous hospital stay. And then there's a bit of a calculation because the blood pressure at night is lower than during the day. Anyway, we have a whole spreadsheet, and you just plug in the numbers and you get a target. So the first step was to show that this mean pressure deficit, this mean blood pressure deficit, and Rakshi used perfusion pressure, so CVP is also used in this program, that had an impact on renal outcomes. So what he showed was the basal blood pressure that patients have and the blood pressure that patients receive in intensive care, and you can see there's no relationship between a patient's own blood pressure and the patients that we are giving in ICU, as you know, because we're always sitting sort of between 60 and 70, around 65. And when you target that, there's a significant proportion in this observational study of patients who have a deficit, a lower blood pressure in ICU than what they normally would have. The patients with a more severe deficit have a much higher risk of developing kidney injury. But this was observational data. Then we did a larger prospective study looking at the same in a number of centers in Australia, patients over 40 on vasopressors, and we looked at the differences between their basal blood pressure and the achieved blood pressure in ICU. And what we found after analyzing more than 12,000 hours of vasopressor use, we found that pretty much all patients had a degree of deficit, and the median time-weighted average, which is just a way of calculating how bad the deficit is over time, was 19%. So it's very common that patients have relative hypotension or a deficit when they're on vasopressor support. And what we found that, I'll just show it on the next slide, that for every 1% increase in deficit, the odds of developing AKI, or make 14, and the definitions are there below, increases by about 6%. So the bigger the deficit, the greater the risk of developing AKI and make 14. We also found quite unexpectedly a mortality impact. So the larger the deficit, the larger the 14-day mortality was. And this is something that we're going to explore in a definitive study in a bit more detail. This has been confirmed by others. Another retrospective study that was published a few years ago that also found that if you have if your MAP target is closer to a pre-morbid MAP, you have a lower risk of AKI. The anaesthetists have done studies intraoperatively looking at individualized blood pressure targets based on patients' own blood pressures and found that if you do that, you do use different blood pressures in theaters during surgery, and there is a decrease, significant decrease, in post-operative complications. This was not a specific AKI study, but just general post-operative complications are reduced when you target a blood pressure that is more likely to be the patient's own blood pressure. Then just recently we published this paper, which is basically the smallest study to see if we can do the bigger study. So we looked at an actual intervention study, because this is observational data, but So does it help then in these patients to target their own blood pressure? If the deficit predicts AKI, well, if you reduce the deficit by pushing up the blood pressure to their own blood pressure, does it then reduce AKI? And it did in this very small feasibility study. So when we did this individualized blood pressure target sort of intervention, we had far less deficit, far less MAP deficit. And this sort of summarized the results. It was a small feasibility study of only 60 patients, but we had a significant reduction in this deficit. And again, even in this small study, we showed a significant difference in the development of kidney events MAKE-14. So this was to inform an adequately powered large study, and that's the last step of this research program, the REACT-SHOCK. We're currently recruiting centers who want to participate, and one of the previous speakers, Marlies Ostermann, is already part of this. So it must be good, right? I mean, because she's like a rock star in nephrology. So, so we have a number of centers in Australia, the UK, Ireland, and the US. Please send me an email if you're interested and if you would like to participate. We're just starting this study right now. To finish off, individualized blood pressure targets for ICU patients. What do we know? We know that relative hypotension related to their pre-morbid blood pressure, and our target is very common and is significantly associated with kidney injury and mortality. We can target a patient's own blood pressure with that protocol that was developed. We're now doing the phase 3 interventional study, and on the next slide is my email address. If you're interested, please shoot me an email. We would definitely welcome any more centers. Thanks very much.
Thank you very much for a very interesting presentation. I think that type of study is a very important step in getting a bit closer to the famous precision medicine in what we're doing. I must say, for my part, having followed the sepsis spam conclusions for many years to increase the blood pressure target in patients with pre-morbid hypertension, I lost faith when the same group of authors published 2 or 3 years ago a reanalysis of the data where that advantage was lost, and the only signal they got was that people treated previously with angiotensin receptor blockers had some signal. And so that, I think, is a bit difficult when the reanalysis of the same data gives you a different response at the end. So that is probably something important to shed light on that very important question.
Yeah, and I completely agree. I saw the paper too, and I was thinking, what's going on now? I think, though, that a diagnosis of hypertension is not sufficient. You need to know the actual blood pressure the patient has, because 50% of patients with hypertension are not treated, or not treated sufficiently. But when someone with hypertension has been on effective medication for 10 years, their autoregulation system is fairly normal. So there's no need to target a higher blood pressure, we think, in patients with adequately treated hypertension for a long period of time, but we don't know that. But that's why we think the best marker of what to target is not a diagnosis of hypertension and whether the patient is treated, yes or no, but is the actual blood pressure measurements that we have of that patient before they come to ICU. I mean, look, it's a hypothesis. We only have preliminary data and observational data, but so far everything points in the same direction.
Yeah.
Thanks very much. Excellent presentation as ever. One of the studies you haven't mentioned is the 65 trial, which those of us in the UK, beat ourselves up trying to get people into with a lot of degree of resistance. And that showed that permissive hypotension in vasodilatory shock, there was no difference. And in fact, patients had a lower exposure to catecholamines, which some people may say is beneficial. And secondary analysis in the chronic hypertension group showed no harm signal. So how do you square that with your personalised approach? My own bias I'll keep to myself. But if we're just thinking about that paper, all right, there were flaws, how would you correlate that to what you're showing here? And you didn't show the 65 trial, that's why I was just interested in it.
I was sitting there, I saw you walk in, and I deleted it from my presentation immediately because I knew you were going to ask this question. It's actually in my presentation, but in the 15 minutes you can only push so much. And I just wanted to make the point around individualized blood pressure. So I'm not entirely sure, but I think, again, the answer to the previous question is relevant. I think a diagnosis of hypertension will still give us significant heterogeneity, because when they are treated well, when they have adequate blood pressure control for a long period of time, it's an entirely different patient group than an untreated hypertensive. So I think we need to know where they sit and look at the deficit. This study will show whether we are right or wrong, but I think that is still too crude. I think it's the same problem. And yeah, that precision medicine is more than just labeling someone with hypertension. We need to know actually what medication is he on and how well is the hypertension controlled.
Thank you very much. Very, very interesting discussion. But the last question, please.
Hi, Frank. Excellent. To make it really personalized, and I think what many people do in the clinic is if you have a patient on a map of 65, diuresis is good, you have no problem. If diuresis is too low and you think or you know he has been hypertensive, we can easily increase blood pressure to a map of 80 or 85. Do that for a couple of hours, see if diuresis increases, then maintain that. If not, go back, for example. Is there any data that you can actually have like this trial and error intervention to make it really personalized and see if your increase in blood pressure actually increases diuresis, and if so, does that predict that you will not have AKI, etc.?
Yeah, I think it's an excellent question, and I knew you were going to make it personal. Yeah, thanks, Peter. I think it's an excellent question. We don't have the data to support that, but I think that's what a lot of people do, right? At the bedside, you look at your patient, there's physiology, you know that there may be something there with pushing up the blood pressure and the response. We don't know if doing that prevents AKI later on, and we don't know if it has any effect on other patient-centered relevant outcomes like mortality or, vasopressor free days. And I think it's quite similar to a lot of things that we do at the bedside, even with sort of a trial of diuretic or a fluid bolus trial. I mean, that's what you do at the bedside. I think it's reasonable to do, but, I'm not sure that it will improve outcomes because we don't have the data.
But it is something that you can do in your trial. Actually, look at those patients that you increase blood pressure. If there is yes or no a diuresis response, can that predict the AKI and clinical outcome benefit?
Yeah, that's a good point. I think we are collecting some of that data, so I'll go and have a look at a protocol. Yep.
Thank you very much. Let me welcome our next speaker. This is the Professor Jacques Duranteau, and he's going to talk about the best vasopressor for the kidney after his excellent presentation yesterday about the microcirculation.
Thanks a lot. So, what is the best for kidney? I just put just one or two criteria because I can put several. To avoid renal hypoperfusion, to maintain glomerular filtration. And it's not only a problem of blood pressure, it's not only a problem of level of pressure, it's very important, it has to be considered, but it's also a problem of stroke volume. And it's important to keep this in mind. So we have to look at the pressure, but also we have to look at the stroke volume. And it's really important to make the part between the balance between vasopressor and fluid. And I think that it's okay that we have to be smarter and to go to a more individualist approach. And but what is the best choice for the vasopressor in this strategy?
So traditionally, endogenous vasopressor has different effect at the level of preglomerular arterial and postglomerular arterial. Just to remember you, the norepinephrine, it's vasoconstriction at the level of the preglomerular arterial, and it's improved blood flow in the renal cortex and the medulla. But in the literature, there is a debate about dose-dependent distribution. The vasopressin, it's a possible preferential vasoconstriction of the postglomerular arterial, resulting in an increase of glomerular filtration. And about the angiotensin II, it's a stronger effect at the level of the postglomerular arterial, vasoconstriction, and it could improve the glomerular filtration by this way. But we have not to forget one thing, is that there is an inflow and there is an outflow so I think that in the future we have to check also this. We use more and more vasopressor, and it's obvious during the perioperative period. We use more vasopressor, we try to target higher arterial pressure, and we decrease fluid. So is this strategy good? In part it's good, but once again, very important to be concerned by the balance between vasopressor and fluid. And you can see it's a retrospective study, but it's a very nice study because a huge population. And you can see that in this study, an increase of, it's during perioperative period, an increase of crystalloid use was associated with a decreased risk of AKI. And I like norepinephrine, and when you look at norepinephrine or the equivalent, you can observe in this study that an increase in the vasopressor use was associated with an increase of the risk of EKI. So we have to be very cautious about this balance between fluid and vasopressor. So the study of Futier during the operating room, and when he targets higher arterial pressure in hypertensive patients, taking in account the level of arterial pressure before the resting level of arterial pressure, but he did not do only this. He also tried to target a stroke volume in this study. And so it's very important. It's not to increase the level of arterial pressure. And what they observe a decrease in the protocol individualized management strategy. They observe a decrease in the probability of organ dysfunction. And about the acute kidney injury, at 7 days, there is a very nice signal. So very interesting study. What about the vasopressin? The vasopressin, you know, this study, the VAS study, it's a multi-center trial. Patient receiving who receive norepinephrine for a maximum of 5 micrograms per minute. They introduce in one group a low dose of vasopressin, 0.01 to 0.03 per minute, and you can see that there is a nice decrease in the quantity of norepinephrine, but there is no difference in survival. What was interesting in this study is that when you look at the more severe patient and the less severe patient, when you consider the less severe patient, there is a signal, there is a significant difference in mortality. And in my point of view, this point is very important, because maybe the more severe patient, even what we do will die. So I think it's very important. Two things is that, do we have to introduce vasopressin as soon as possible? And do we have to stay at low dose of vasopressin? I think it's very important to ask this question. And in the post hoc analysis of this study, looking at the risk of acute kidney injury, it was the classification was a referral classification. When they look at patients who are at risk of acute kidney injury, there is with vasopressin a decrease in the probability of survival looking at this patient. With for failure and loss, there is no difference between the two groups. So the VANISH trial was very important because it was really the early introduction of vasopressin versus norepinephrine. And but what the primary outcome was kidney failure-free days during 28 days period after randomization, but they observed no difference between the two groups. So very disappointing. I was very disappointed. I cry a lot. The rate of renal replacement therapy in these two studies, there is a signal in favor of vasopressin, but the use of renal replacement therapy was not controlled in this trial, so very difficult to make conclusion. But there is a very important point in this study. They leave physicians do what they want. Sometimes it's very smart, sometimes not. I don't know. So concerning hemodynamic profile, no information, not enough information, just a mean arterial pressure, a target of mean arterial pressure. And I deeply think it's not enough. When we have to deal with this patient, it's not enough. So I don't know what is the fluid, the volume status of this patient in the two groups. And it could make the difference, really. So for me, there is room for other trial in a septic patient with vasopressin. And in cardiac surgery, after cardiac surgery, there's a very nice trial where they compare norepinephrine and vasopressin. You can see that the dose of vasopressin was slightly higher. It's, you can increase the vasopressin until 0.06 units per minute, so higher than in the VANISH trial. And the primary outcome was the post-operative complication after cardiac surgery. So it's clearly, it's not a septic shock, it's a vasoplegic shock, so the story could be different. But when they observe the primary outcome, there is a difference in favor of the vasopressin concerning the post-operative complication. And looking at the acute kidney injury, it's very impressive. So my smile come back. You know, life is very simple. And when you look at the acute kidney injury, it was classified by Akin classification. You can see that the effect was in the more severe acute kidney injury. And this is a very important point, because if it's only on EKI 1, we know that many things can reverse the situation. But in 2 and 3, it's more difficult. So for me, it's a strong argument. And they also observe a decrease in arrhythmia, which is a plus. So I think you understand that I deeply believe, I like norepinephrine, and I deeply believe in vasopressin. So I try to find the pleasure everywhere. So we designed a trial during hepatic transplantation. It's a randomized trial. We will start in, I hope, in September. And it's a comparison between norepinephrine and norepinephrine with low dose of vasopressin. Let's see, the primary outcome is the acute kidney injury after this hepatic transplantation. You know that the rate of acute kidney injury is very high after transplantation. So I'm very excited about this. What about angiotensin II? So there is one big trial with angiotensin II, and they use angiotensin II to increase the arterial pressure, and it works. They were able to largely increase the arterial pressure. And they observe that when you use angiotensin II, you can decrease the quantity of vasopressors that you give, but without effect on the SOFA score and without effect on the acute kidney injury. In a sub-analysis of this study, they look at a patient who had acute kidney injury and who need renal replacement. What they observe that in this small population, it was 45 patients and 60 patients, they found that the 20 days survival was better in the angiotensin II group, and the renal replacement therapy liberation was greater in the angiotensin group. So we have two small data in angiotensin II to establish conclusion, but I think it's a very interesting compound, and we need more experimental and human study. So in conclusion, early administration of vasopressor must be used to maintain arterial pressure and renal perfusion, in addition to an optimization of stroke volume, and we need to monitor these patients if we want to decrease the acute kidney injury. Not only monitor the stroke volume, but also to go deeper with using echography to see if there is also congestus venous component. And vasopressor, if I believe in the trial after cardiac surgery, may be preferable to norepinephrine as the first-line vasopressor agent in vasoplegic shock. And in septic and hemorrhagic shock, the potential benefit of vasopressin on renal function should continue to be tested. And about angiotensin II, we have maybe 10 years of work to find if it's beneficial for the kidney. Thanks a lot.
Thank you very much for this wonderful overview. Is there any questions? Yes, please.
Thank you. Actually, it was a question for the previous speaker, but as you mentioned the venous congestion, it will fit your talk as well. So we are talking about blood pressure target, okay, in these talks, but as you mentioned, is the importance of venous congestion and downstream pressure behind the kidney. So would it make sense to study rather not the blood pressure in absolute value, but the gradient of the perfusion pressure between the two? So in other words, mean-arterial pressure is minus CVP, for instance. Or
Yes.
mean-arterial pressure and the venous congestion with ultrasound, whatever.
In my point of view, it's very important. You have to check this in your patient at the bedside. You have to know what is your CVP, do you have, what is your flow, the venous flow at the kidney, you have to, I think so it's why it's very important to take in account the arterial pressure, the level of arterial pressure, and I'm completely agree that it's very important to test things. See if you have an improvement. Increase the arterial pressure to see if you have an improvement. And what is the improvement? It's another question. So it's important to take this in account. It's important to take the fact, the venous return at the level of the kidney. It's also important to consider if you have or not a compartmental syndrome. For example, when we talk about cirrhosis, you have to look at this. When you talk about post-operative patient, you have to think that maybe you have to call your surgeon because there is a big abdominal syndrome.
If I may add something.
Okay,
so
just a short question, because we have half an hour for the last two presentations.
I know. Just you're absolutely right. And if you paid really well attention, we are actually doing mean perfusion pressure, MEP minus CVP, and not just blood pressure targeting for that reason. But I didn't want to confuse people anymore. But yeah, you're absolutely right. CVP is essential as well.
Okay, as I said, we will have to move on to give the last two speakers their full time. If there is still time at the end, we can come in with the questions then. It's now my honor to invite Professor Patrick Honoré to give his presentation on vasopressin could have renal protective effects.
Thank you, Mr. Chairman. Dear colleagues, so my friend and previous speaker has probably said quite a lot about vasopressin, but thankfully we have a different view on it, and maybe we can reconcile perhaps. Okay, so my task in the next 15 minutes would try to convince, if I may say this, that vasopressin could have renal protective effect. Now, we will tackle the pathophysiology of kidney microcirculation regarding to sepsis, noradrenaline, vasopressin. Briefly, what about noradrenaline and the kidney? Maybe a different view here. Let's see. Urinary PU2 close to medullary PU2. What about vasopressin versus noradrenaline in ovine septic shock? Well, a nice model, very close to the human situation. And then, obviously, what to think about in humans, and the previous speaker has already done a lot of work on it. And then, what does tell us a recent meta-analysis on the topic and some conclusion. Now, this is really crucial because we need to know exactly what's happening at the microcirculation of the kidney and the glomerulus here. And so, what does sepsis? Well, normally you said sepsis would vasodilate it, but look, in the afferent arteriole, it vasoconstrict. This means that you will have a reduction of GFR. That's very bad. Agree. And then you have a vasodilation of the efferent artery, which is again very bad, because this will also further decrease G4. Bad luck. Right. Now, what about vasopressin? Interesting. So if we focus here, efferent artery, in fact, the vasopressor effect of vasopressin at low dose act predominantly on renal efferent arteriole and has negligible effect on the afferent arteriole. And by doing this, it increases the GFR. Pretty nice. Okay. Now, what about noradrenaline? I agree with my good friend and previous speaker that there are some discrepancy in the definition of the effect of noradrenaline. I took the one from Bellomo's group, who has quite a lot of experience in this. And according to Bellomo's group, it indicated that norepinephrine caused severe focal constriction of afferent arteriole. And if you do this, you have a decrease in GFR. And I will show you later. And because you have no effect on the efferent arteriole, you have only the very bad effect of reduction in GFR. Okay. Now, coming back to noradrenaline, very nice vasopressor, I agree. But in this very nice experimentation by the group of Bellomo, we see noradrenaline versus saline, and you have here urine flow from the ovine septic shock model, a nice model really. And you see that in closed square, the urine output of noradrenaline is decreasing, whereas saline is somewhat increasing and stay stable throughout the experimentation with E. coli infusion. Regarding creatinine clearance, you see that there is still a trend in favor of saline, the closed circle, but this time this is not significant, probably to the small number of peaks of sheep, obviously, although there are numerous in New Zealand. This is a joke, obviously. So, if we look to another table, we see that indeed, as time goes on, you see that the medullary PU2 in open circle is decreasing, almost half, so much. And we see that the urine flow here is also decreasing, and the urinary PU2 is following this medullary tissue PU2, saying to the group of Bellomo that it might be in the future a good manner, very easy to try to measure the medullary oxygenation, which is so important. Now, we could say in conclusion that there was a rapid and selective reduction in medullary tissue perfusion in hypoxia, despite increased total renal blood flow. Therefore, I don't like very much doing renal Doppler in the renal artery, because it's divided in cortical flow and medullary flow. But what does tell is the medullary flow. I don't care about the cortical flow to some point, obviously. So, we see that the dose of noradrenaline exacerbate the medullary hypoperfusion and hypoxia, and that resuscitation with norepinephrine change in urinary PU2 closely parallel the change of medullary tissue PU2, probably something for the future. Okay, now put everything together. So we have a norepinephrine dose of 0.4, 0.8 mics per kilo per minute. Don't do this. Don't measure the Doppler in the renal artery. It's going to be high. The kidney is safe. My God, no. Look, the medulla, it's hypoxemia. Ooh, very bad. and then the correlation between the urinary PU2 and the PU2 of the medulla. Now, coming to the heart, let's say, of this talk, beneficial effect of vasopressin compared with norepinephrine on renal perfusion, oxygenation, and function in experimental septic shock in the ovine model by the group of Bellomo. And as you can see, if you look in a closed circle here for vasopressin and then open cubic for noradrenaline, you see a very strict difference in terms of renal oxygen delivery and also on oxygen consumption. Oh, and this is obviously a key point because physiology and pathophysiology is always the mother of medicine so far. Right. What does mean in clinical terms? Well, we reproduce a better urine output for vasopressin, and we have a better sodium fraction excretion with vasopressin. All goes into the same direction. Okay. Now, you may say, well, if we have refractory septic shock, like one of the previous speakers said, and you have very high dose of vasopressin, we may have problem with the mesenteric flow. Well, in this case, the mesenteric blood flow was maintained, and the conductance, which is the reverse of resistance, was also maintained, which is very good news. Now, in conclusion, in this type of ovine septic shock, restoration of mean arterial pressure with vasopressin induces a more sustained improvement in renal function than norepinephrine without exacerbating renal medullary ischemia and hypoxia, and without reducing mesenteric blood flow below baseline value. Okay, now this was about ovine septic model. What about adult? And I will be more brief than my colleague because he said most of the things. But here you have really to focus on two numbers here in total, which is the percentage of RT, 25% versus 35% here. And this was vasopressin versus norepinephrine. So more patients were needing renal replacement therapy. Although I agree that there were no other signs of acute kidney injury, difference in acute kidney injury between the two groups. And this is strange. And I agree also that RT is a decision of a clinician. But do not forget, this study was a double-blind study. So if someone is making more RT in, let's say, in an hospital, he would do more RT in the two groups. So we have to be cautious about the interpretation. Now, in a recent meta-analysis, having obviously one of the major studies in, but some more as well, they state the same statement as my previous speaker, that vasopressin is the first-line vasopressor in septic shock with a significant reduction in RT. Okay. Now, Mr. Chairman, if I may conclude, I would say Vasopressin, in terms of pathophysiology, at the microcirculation has the best profile. No really doubt about this. Noradrenaline is worsening the microcirculation and decrease the medullary oxygenation as well urine output and GFR. Urinary PU2 might be a good marker of medullary oxygenation. That's for the future. Vasopressin compared to noradrenaline in an ovine septic shock model is superior in terms of urine output, GFR, and medullary oxygenation. VANISH is a double-blind RCT, show a significant increase in RT need for noradrenaline as compared to vasopressin. A recent meta-analysis confirmed the superiority of vasopressin over noradrenaline, but we need more study. We need to be cautious to see if new large randomized controlled trial with the primary endpoint of comparing vasopressin versus noradrenaline will confirm or not the superiority of vasopressin in protecting the kidney. Thank you so much for your kind attention.
Thank you very much. I think we move on to the final speaker. I will take questions if you have time in the end. Thank you very much.
Let us welcome the next speaker. This is Professor Lui Forni, and he is going to talk about the very interesting topic, at least for me, bicarbonate administration. Is it good or bad?
Right, I know you've got other places to go to, so I'll try and get it done in 10 minutes, all right? We won't talk about conflicts of interest, apart from this one, that I've gone so conflicted about bicarbonate that I wrote papers about it in the last millennia. So it's worth bearing that in mind. Now, The Good, the Bad and the Ugly, you all remember that movie, hopefully. Clint Eastwood is probably the good guy, but there's some discrepancy over who the bad guy is, as you can see from the Italian poster. So it's a bit like that with bicarbonate. You know, some people think it's good, others think it's bad. What's interesting about this film is this is Eli Wallach, who was one of the stars. He nearly died 3 times when they made this film. First of all, he was hit by rubble from an explosion. The explosive guy got sacked. Secondly, he had to hide from a train, and they forgot that American locomotives have a skirt, so it missed him by inches. And the third thing, unbelievably, is that he drank acid accidentally from a bottle, right? And was treated by a quick-witted physician who gave him bicarbonate. So that's good news. So here's the bad face of The Good, the Bad, and the Ugly. So this is some of the criticisms of bicarbonate buffering. So one of them is that you end up hypovolemic and hyponatremic, because patients with severe metabolic acidosis are almost certainly oliguric and or anuric. So if we give them large doses of lower concentration bicarb, you get significant ECFs expansion. If you give them smaller doses of hypertonic sodium-containing bicarb, they become hyponatremic. So that's true, yes. But how do we get around that? Well, we get around that by using bicarbonate buffered hemofiltration. So if you've got severe metabolic acidosis and you're anuric, then probably you should think about wheeling out the machine rather than giving more fluid. The other thing is there's criticisms about decline in the pH of the CSF. Sometimes when you use in metabolic acidosis, there's no need to really be concerned about that with bicarb because it doesn't affect it, and it happens in sepsis whether you give buffer or not. This is one of the other major criticisms, that tissue hypoxia. It's well established with the Bohr effect that the intraerythrocyte pH affects the affinity of hemoglobin for oxygen, and some people believe that acidosis can be effectively protective in terms of oxygen delivery. But you've got to remember that acidemia has significant effects on other parts of the body, apart from just the erythrocyte. And if we correct acidemia, which is negatively inotropic, we know that we can get improved cardiac output and oxygen delivery. And in fact, the inotropic effect of alkalemia goes above normal pH, which has been shown in animal studies. This is probably the one that gets thrown at the bicarbonate zealots like myself the most, that you can get venous hypercapnia leading to so-called paradoxical intracellular acidosis.
it's worthwhile bearing in mind that most of that comes from isolated cells and animal studies. This particular reference here gets a lot of traction. It's from Jim Ritter's group in the early 90s from guys. And what they've actually quoted in that paper is that the use of bicarbonate is both illogical and dangerous. This was based on a study on isolated platelets in an alkalotic buffer, right? So that experimental data led to a lot of bad press about bicarbonate. Certainly it entered the anesthetic literature. This just goes to show the paradoxical acidosis. Effectively, you get more CO2, which goes into the cells quickly, recombines, and you get proton release and acidosis within the cell. I haven't got time to go into that in detail. But what I will tell you is that we looked at this in cellular models, as I said, in the last millennium. Now, I'm going to show you some cellular work, so it's not nice and clean, but it's probably just worth looking at. So this is a white cell with a dye in it, pH-sensitive dye, and here's the pH. We gave him a big bolus of bicarbonate, far exceeding any clinical dose, and you can see the pH goes down. Right? Fixed ventilatory constraints. We didn't blow off the CO2 in any way, and you can see that you get a paradoxical acidosis in that condition. Whereas if you give the bicarbonate in slow aliquots, you might get some decrease in pH, but not much. But if you give a large bolus, you again see a paradoxical intracellular acidosis. And you can actually make the pH go up, down, or stay the same, depending on what you want to do. So if you take cells in an isolated buffer system without controlling their CO2, giving them huge supranormal doses of bicarbonate, then they'll get an intracellular acidosis. You don't do that to your patients, or if you do, you should perhaps consult your lawyers. So this is the good guy, right? So bicarbonate has been shown to be good in a slightly surprising way. So you'll probably be aware of Samir Jabbar's Bicarb ICU study, which looked at metabolic acidosis and treatment of bicarbonate. And the rationale for this study was very reasonable. That a lot of people bad press bicarbonate, and yet about 50% of ITU practitioners and nephrologists would suggest using it with very little scientific base. This was the randomization protocol. I won't go into that now. These are the primary endpoints. Right? Whether there was any effect on mortality, no. So effectively the take-home message is that bicarb ICU didn't show any benefit apart from in moderate to severe acute kidney injury, where there was a reduction in both the amount and the mortality. Now bear in mind the study wasn't powered for that, but it's quite important to consider. There was also this, and this is the bit that really caught my eye. This was a dramatic reduction in the amount of renal replacement therapy. So the patients who received bicarb, if they had acute kidney injury, did better and got less RRT in the current drive to give less RRT. This triggered lots of meta-analyses, as you can imagine. This was one from China using the MIMIC-2, showed a benefit in AKI, quite significant, but said perhaps we need more studies. This was another study from Australia, scoping review, Rinaldo's group. Again, said, yeah, there seems to be a signal, we need more studies. You know what's coming next? Yeah, we need more studies. So the ICM ran a three-way debate, the Janus faces of bicarbonate therapy. This was the pro arm from Boris Young and Samir Jabbar. And they did show that the primary endpoint in terms of sepsis, it wasn't a benefit, but it was in terms of acute kidney injury. But then John Callum said that he thought this was all very bad news. He thought bicarb ICU was a bad study because it was unblinded. Well, you should be able to work out who you're giving bicarb to, but anyway. The need for renal replacement was left to the clinical discretion. Well, okay. And it wasn't powered for the effect on acute kidney injury. So that's true, right? And there were other criticisms, which I'll briefly outline. The key to correcting acidemia in critically ill patients is to identify and treat the underlying cause. Yeah, absolutely, I'd agree with that, and anyone who uses bicarbonate would agree with that. It isn't a treatment, it buys you time to do what you need to do. The use of bicarbonate or even RRT are at best adjuncts. Yeah, but a lot of the stuff we do are adjuncts, right? Vasopressin, as we've heard, might rescue your kidney, but it actually buys you time for other things to kick in. And although carefully selected patients may benefit from such therapy, the average patient will not. I mean, you know, I just don't know what to say to that, really. You know, we now go to lectures all the time and talking about personalisation, and yet one of the criticisms is that, you know, if you use it personalised, well, it might work, but in general it doesn't. Well, don't know. Increasing SID, right, that's one way to really get my back up, can lead to alchemia. Well, I don't believe that, and I've never seen seizures after bicarbonate infusion. And so we were kind of not sure. We sat on the fence, which is unusual for me, but the basic tenet meant that the underlying cause of the acidosis should be addressed, and interest should be focused on metabolic acidosis and acute kidney injury. And I think that's reasonable. And this is the Janus Gate in Rome, which I think still stays open for the use of bicarbonate treatment. So unsurprisingly, Bicarb ICU2 is being run now in France. You can see it started in 2019, so something happened to delay that trial somewhat. And this is a study we're doing in the UK, the Mosaic study. We're aiming for a somewhat ambitious figure of nearly 2,000 patients. Very slow start, what we're beginning to hit recruitment targets now. So hopefully the NHR will keep us going. So my conclusion to you would be, yes, in selected patients with acute kidney injury, bicarbonate is probably good. And I'll remind you that you give bicarbonate almost certainly every time you put someone on a filter. So bear that in mind. And we may find that from Bicarb ICU and Mosaic that the use of bicarbonate in select patient groups with metabolic acidosis, acute kidney injury, translates to not only a patient benefit, but a reduction in resources. And with that rather rapid talk, I bring it to a conclusion. Thanks very much.
Okay, thanks for your rapid presentation. We have time for one or two questions for the last two speakers, if there is some comments or questions.
I have a question, Professor Forni. One question. What about combined acidosis, metabolic and respiratory? What do you think about this?
When you're faced with that, you know, I deal with the respiratory acidosis first. Right? So, you know, I'll bang them on a blower, get the CO2 down, and then see where we are. And it may be that the metabolic acidosis is then less of an issue. But, you know, in that case, I'll give bicarbonate, but you'll control your, you know, ventilatory equivalents to make sure that your CO2 doesn't rise. So, yeah, I think there are other things to do.
And what about using extracorporeal blood purification technologies to correct severe lactic acidosis, severe metabolic acidosis as bridging to whatever course of therapy?
Yeah, I mean, we showed that over 20 years ago that we can do that in lactic acidosis. So yeah, there are other ways to treat it. And I'm not saying that bicarbonate's the only treatment, but what I'm saying is, you know, something obvious may be staring us in the face, which we've ignored for some time. So. Okay. Please. Frank.
Just on the inotropic effects or negative inotropic effects on acidemia, how come patients with severe diabetic ketoacidosis and a pH of 6.8 don't have a negative inotropic effect of their acidemia?
Well, I think they do, actually, if you look at it. Yeah, and, you know, I've seen that. I mean, invariably, they're younger, of course, so the presence of comorbidities tend to mask some of that effects. But, I mean, I think they do. And they're not septic, so I think sepsis and the negative inotropic effect, then you see, you know, it's more than additive.
Yeah. My question goes to Jacques Duranteau. Is he here? No, he left.
Jacques probably giving a lecture somewhere else now.
Situations where the chloride is high and the strong ion deficiency is low, so in relative terms the sodium is low compared to the chloride.
Yeah,
Is there a role for bicarbonate there?
There could be. Yeah, there could be. You're talking to the wrong guy here, right? I mean, I trained as a chemist, and I can tell you, if you brought any chemist in here and talked about strong ion difference, they would think that you'd landed on the moon. right? I mean, I have never seen any evidence that changing ionic concentration affects your pH, right? Peter Stewart was a brilliant guy. He liked maths, right? But, you know, I don't get it, and I'm not the only one. So, all right, chloride has negative effects in terms of, you know, vasoconstriction, for example. I buy that. It's a sadly neglected anion. Luciano Gattinoni is one of my best pals. We never talk about strong ion difference because it just causes too much of a rise in blood pressure.
Thank you very much for your participation. Thank you very much for all the speakers. Thank you for your attention, and we have to move because the other session is going to start.